I'm going to give about like 5 more minutes or so, and then we'll get started to catch all the stragglers. Oh. Yes, ma'am. Did you have a question, Hannah? Okay, I just posted the link for the sign in on Facebook, and I also sent it on email. So when y'all get a chance, if y'all wouldn't mind signing into that, please. And y'all can hear me, right?
We can
Yes.
hear you.
Okay, cool. Okay, let me get the PowerPoint up. And then we can get started. Okay. Alrighty. So y'all ready? Looks like as many people are here as are probably going to get here. So, okay. So, there's 30 questions, and I'm thinking we'll probably be done early, like in less than 2 hours. But as my dad and brother like to remind me constantly, my concept of time is pretty near shit. So we'll see how it goes. I do have the poll thing that should be working. So we'll see if that works out. That way nobody has to be like super brave and take a stab at a question, although I'll still have some audience participation. Hopefully some people will play along with me there at least. Let me think if there's anything. Let's see. I'm looking at the chat thing.
That was me. I just had a kind of like the Excel sheet didn't load until a second after I had put my name in, so I didn't know if I replaced somebody.
Oh, okay, gotcha. Yeah. And y'all don't have to fill that out like right at this moment. If it's like super busy or whatever, y'all can just fill it out at some point. That would be great, some point tonight. Okay, I'm super bad at checking the chat, so if y'all have anything that y'all want me to know specifically, it's probably just best to tell me. But and let's see what. Okay, so as far as like what to expect on this unit test, on the 2 psych tests, a lot of it's really fairly straightforward. They kind of flipped it for y'all a little bit. So we actually, the unit that y'all will have as unit number 5 was actually our unit. It came before y'all's unit 4, so they kind of flipped the 2. So this one I'm thinking is actually probably going to be fairly easy for y'all because there's not much of a differential to work with. A lot of it will be like, how do you talk to a patient? There'll be a lot of ethics-y type questions, which can be hard if you overthink them, but we'll go through a few of those. I'll try to touch on like the really main points that they'll expect you to know, some things that are kind of confusing, and also some things that'll definitely be tested on your NBME. The NBME for this one, they kind of pull in a lot of stuff from some stuff from neuro and like some stuff that's just kind of random that doesn't seem to really fit well anywhere. Like I remember on our test, there was some healthcare system types questions on there, which is not really something they cover in this block. That's more of like a P3 thing for our school. So, but I can cover more of that next unit when we do the review. So I'll stop talking now. I will, let's see, share my screen. Okay. I want to move that. Move, still. I want to do that. Okay. So y'all should see the PowerPoint now, right? Is that correct?
Yes.
Okay, perfect. Alrighty. So we'll go to, I'll put the question up there and then, go back. Okay, there we go. So I'll put that up there. And then what I'm going to do is I'm going to send out the poll. Okay, and so how this will work The first 5 questions are going to be doubled up. They'll have number 1 and number 26. Don't worry about question number 26. Just worry about question number 1. It only lets me have like 25 individual poll things. Yeah, anyhow. So I'll give y'all some time to look at the question and answer that. And then I will stop polling here in a second. Y'all should see the poll, right? Y'all see the poll question? Oh, shit.
Yes.
Where it went. Okay, do y'all need more time or are y'all good with the questions there?
So did you want us to submit? Because I think I can only submit if I answer both 1 and 26.
Oh, is that right? Okay, well then just go ahead and just click something for 26 then if you need to submit it.
Okie dokie.
Okay. Two more people. I guess we're not playing along. Okay, we'll stop it there. Okay, so can y'all see the results there or no? Here, maybe if I do that. Now y'all should probably see them, right?
I see him.
I see him.
Okay, awesome. Okay, the color that's orange doesn't necessarily mean it's the right answer. It's the one that was picked the most, but in this case, it is the right answer. So here, I will shut that down for actually, yeah, okay. Okay. Okay, so yes, that is correct. So this question really is kind of straightforward. Either you kind of know it or you don't. And so the greatest risk for suicide is a previous suicide attempt. That'll be tested, likely to be tested on your upcoming unit test. It'll be tested on step 1. It'll look at questions very similar to this, where they give you a person with all kinds of problems, a whole slew of risk factors, and they are going to ask you which is the biggest one. It's always going to be a previous attempt. These other things are certainly important. So why would some of these other things be important? Say substance use or social isolation, cutting behavior. Why are those important risk factors?
I mean, they show a state of like severe depression.
That's true. That's true. And so why, so that you're correct, but why particularly would say, why would I maybe focus in on substance use versus say a family history of suicide? Why would that maybe be more important to me as a clinician?
Because it's dependent on your actual patient. Even though family history of suicide does cause a lot of negative thoughts and emotions, and it's a traumatic event, the patient's his or herself, I mean, you got to focus on the patient.
Yeah, that's exactly right. So those are all what we call modifiable factors, which will be an important deal when you are actually on your psych rotation, because those are things that we can actually target in a patient to reduce their risk. Things like a family history. Yeah, you're exactly right. That's a risk factor. You probably want to get them in some kind of therapy or some kind of psychotherapy or counseling or whatever, but that's not something that you as a clinician can impact or change. Whereas those other things are modifiable factors, which is important as a clinician. Let's see, what else is important on here? So while we have risk factors, we also have protective factors. So some important protective factors that could be testable are things like social support. That's always a big one. Family connectedness. Pregnancy is a big protective factor. As well as parenthood or being a grandparent, having some kind of someone who they feel responsible for, particularly someone like not an elder that they're responsible for, but a child that they're responsible for. And also religion is also going to be a protective factor. Another point, so what is the greatest or strongest risk factor for homicide, for predicting homicide? That's another testable feature.
Maybe social isolation.
So that's a big one. Social isolation can be one, certainly bullying, sexual abuse, or any kind of abuse for that matter. Yeah, so social withdrawal, all those things can be risk factors for sure. We hear about that in the news all the time when there's a school shooting. But there's one that's actually a greater predictor.
History of violence or something like domestic partner violence or them being an abuser type thing.
So you're exactly right. Kind of like with the history of a suicide attempt, certainly a history of like violent behavior in the past, or committing homicide in the past would be a risk factor. But there's still another one that is that they'll test you on.
Violence towards like animals.
So you're thinking about antisocial behavior and conduct disorder, which you're exactly right. So I'm sorry, I'm making y'all kind of guess my mind here. The question that they'll ask on STEP is, you're exactly right about all those things, but access to a gun is one of the things that they'll put as one of the strongest predictive factors. Certainly that's not the only way you can commit homicide and that whatnot, but that's something that they just like to test on. Okay. Alrighty. I think I've beaten that dead horse, haven't I? Okay. Next question. Let's see. So stop sharing the results. Let's go to question 2. Alrighty.
For question 2, is there an answer choice beyond G? It kind of cuts off for me.
No.
Thought
G
you can
should be the
scroll.
last one.
I think mine scrolled down and had more.
Okay. Yeah. G should be the last one though.
Okay, when I scroll, it just takes me down to 2, but if
Oh,
it's
you mean like the
G,
answer choice itself is cut off?
yeah, I can see half
Oh.
of G, but I can understand like what the answer is saying if that's all there is.
Gotcha. Yeah, it just wants you, the part that I think is cut off is meeting. That's the last word there. Okay, let's see. A few more people still going in. Okay, I'm gonna call it. Alrighty, so on this one, so let's see, it looks like y'all all liked F. However, F is not the correct answer. So A is going to be the correct answer here. So on this one, so first off, what are we talking? What strategy are we employing here?
The expert, but we're doing that lecture tomorrow.
Oh, y'all haven't done that yet? Oh shoot, I'm so sorry.
That's
Okay. Yeah, it's expert. So motivational interviewing. Dr. Trotter loves this. So okay, so I guess I'm sorry, I didn't realize y'all hadn't done that yet. But so with this, so what it is he'll talk to y'all about how there's different stages. And so this patient would be in the very most preliminary stage, which we call the pre-contemplative stage. And what that means is this patient has not yet recognized that there's a connection, or if he has recognized that he isn't willing to admit it yet, there's a connection between some undesired behavior and these negative impacts on his life. So he's able to see that not attending his daughter's game is an issue, but he's not able to connect it, or not willing to connect it to his alcohol use, and is not willing to admit that there's a problem. So let's see, what was F? So the reason that, well, somebody who didn't pick F, what do y'all think might be the reason that F is not something we want to say at this point? It might be at a certain point in time, particularly if we go to like a psychotherapy route with him, it might be something we'd want to say then, but what would maybe be the potential problem with saying it now?
Maybe because he hasn't even recognized that it's a problem yet. And so you're already assuming the fact, so he might be like really hesitant to agree with you at that time.
You're right about all that. The thing though that here that particularly is wrong with F is that you would be kind of taking his wife's side with this. So he already admits he says his wife nags on him a lot, I think was his wording. What was it? What words did I make him say? She's always criticizing me. We fight a lot. So by asking, well, is your wife upset? It might seem as though you're kind of taking his wife's side, and so that could impact the patient-physician relationship there. So that would be why we wouldn't want to go with that one. With these types of questions, something that you kind of have to look at is so you kind of want to identify where the patient is so far. So it seems like you correctly identified that he doesn't even realize that he has a problem yet. And what you want to do, you want to kind of ask a question that helps them make that conclusion on their own, because you're trying to get that awareness. So what would be wrong with B right here?
You
Most
don't want to
people
scare
can't
the
read.
patient. Oh, I'm sorry.
No,
Oh, no,
good.
you're good, Michael.
So yeah, so that could be one thing. What were you gonna say, Bailey?
Just that, like, the scare tactics are saying, like smoking will give you lung cancer doesn't typically seem to work with people who have an addiction problem.
Mm-hmm. Yeah, so you're correct. Fear is a powerful motivator, but an unpredictable motivator. So it can motivate them to do something you don't necessarily want them to do. There's a time and a place to communicate with them, and to kind of not employ a scare tactic, but to kind of be blunt with them. However, you've already kind of indicated to this person that it could be hurting his liver, and he hasn't really seemed to latch on to that. He doesn't really seem to care or recognize, what all problems that entails. Another thing that is kind of a rule of thumb with these types of questions, not necessarily, a hard and fast rule, but if you're asking like, what should you do next, you like probably 8 or 9 times out of 10, you want to pick up something that has a question mark at the end of it. You don't want to pick something that's just giving you, or that's just giving the patient information, if that makes sense. So for the same reason there, also C would maybe not be the best answer, because you want, especially if we're talking about motivational interviewing, you want to get the patient talking about his thoughts, his emotions to that. And particularly, which is something you'll go over tomorrow with Dr. Trotter with Espert, is you want to when you employ this, you want to start with something, like you want to start with making a connection with the patient. So I understand that you enjoy drinking, so you want to let them know that you see where they're coming from. You're not totally disregarding them. But then when you finish your statement, you want to end it with something that gets them talking about the reasons why they don't want to do it. So gets them talking about the negative aspects of whatever behavior it is you're trying to change. Let's see, what other answer choices are there here? D, that would probably not be great. Someone's probably not going to respond well to you telling them that they're in denial. Why would E not be a good one right now?
Unrealistic goal.
Yeah, and also especially if they're resistant to quitting, that's going to seem, when you come at them with this very extreme, it's likely to shut down any little bit that they might have been willing to go, because they're going to see it as an all or nothing approach. So you want to kind of give little increments until they're fully bought in, and that's something that they want to do. That's not even something he wants to do right now. And Alcoholics Anonymous, by asking him that would also be kind of accusatory. You want to try to avoid that. Does anybody have any questions? I know that these are probably the types that they're hard. It can be hard to answer. Are there any questions on this that I didn't address that y'all still have about questions like this question here?
I don't want to take up too much time, but
You're good.
the reason why I picked F, and I understand why A is, and we haven't had that lecture yet, I get it, but that kind of goes in with that cage stuff they teach us in docs. Like, you got to ask them, have you thought about cutting back? Is anybody annoyed with how much you drink, etc.? So you know.
Yes, I see where you're coming from. So you're about asking about the cage questions. So the difference here is that cage questions are screening. So that would be if we weren't sure yet if this patient had an alcohol problem or not. So let's say that the question was, instead of written like this, let's say that a patient came in, maybe he's missed work a few times. Maybe he says, well, I go out for a social drink or something, and we're not sure yet if he actually has an alcohol problem. We as a physician are not convinced yet. Then that would be when we would employ the cage questions. With this, it's more of a definitive. We already, the flavor of the problem is that they're basically kind of handing you the fact that he's an alcoholic, and they want to know what you're going to do next. Another thing, and I'm not trying to like argue with you or shoot you down, just trying to.
No, I appreciate it. That makes complete
sense.
Good. Thank you.
Yeah, you're welcome. And the other thing that I was going to say too, just to help you in the future also, is that when you do ask those questions, you probably don't want to give a specific person in their life, especially if they've already mentioned that they're having conflict with that person. So when you ask the question, it would be like, has anyone, like just like a general question, has anyone ever expressed concern about your alcohol use, instead of, well, I fight with my wife. Okay, is your wife upset about this? Because then it's more accusatory, if that makes sense.
I got it. Thank you so much.
Yeah, you're welcome. You're welcome. Does anybody else have any other questions on this one? Okay, I do have a few more that are kind of similar to this one, not Espert, but like patient communication wise. So you'll get some more practice. Hopefully that'll help. Okay, here's the next one. I will get the poll out. There we go. Okay. Give you a few more seconds. Okay, I'll end that. Okay, so let's go back to the question here. Y'all did answer correctly. So what's going on with this patient here?
Is he having some sort of withdrawals due to the anesthesia and the painkillers?
So he's having withdrawals, not from the anesthesia or the painkillers though. Does anybody else have another, want to take a, have another idea? Or Michael, if you have another idea also?
Well,
No, I got it wrong.
Withdraw, withdrawal from alcohol would have seizures.
Yes, so yes, he's withdrawing from alcohol, and you're right, the danger of withdrawal from alcohol is seizures. So several things to break apart in this question. The first thing, so there's 2 withdrawal symptoms. Y'all have had the substance lectures, right? Substance abuse lectures?
Yes, we have.
Okay, perfect.
most
So
of them.
there's 2 withdrawal syndromes that could potentially kill you. What are those 2 withdrawals? Withdrawals from what?
Benzodiazepines and alcohol.
Yes, correct. And why, what can kill you? You already said it, but just to connect the dots, what can kill you about those 2 withdrawal syndromes?
I assume seizures.
Yeah, the seizures. The seizures are what would kill you. Yes, exactly. So this patient is having withdrawals and from alcohol. So specifically based on his symptoms here in the time frame, because this is what, his 2nd day of hospitalization. Yeah. A day. Okay, so a day ago. So okay. So so what specifically would we call this constellation of symptoms right here with these tremors? Yeah, what would we call this?
Is it delirium tremens?
Yes, exactly.
Okay, follow-up question.
Mhm.
How do you know that this is alcohol abuse? I mean, maybe I'm an idiot, but
No, you're not an idiot at all. This is a really difficult question, and that's why I put this on here. So on your exam on Friday, you will probably not have a question that's difficult. One, this is fair game. So there's several ways, several clues that you kind of need to piece together here. So first off, you can look at the labs, which I know that y'all haven't had major SD1 yet. However, the ALT and AST, these are elevated, right? But there's something specific about these, a pattern with these right here. Does anybody know what pattern I'm referring to here? Can y'all-
AST is
AST is
times the ALT.
twice. Yeah.
Yeah, I think y'all just said it. Yeah, the AST is more than twice the ALT. So so yes, that is the thing there. Let me see if I can get yeah, y'all can see that? Yeah, okay. Yeah. So normally if you have just like normal liver damage, the ALT will either be higher or like about the same as or just a little bit lower than the AST. However, if the AST is significantly higher, typically we say more than twice, then that's an indicator of chronic alcohol abuse. The reason, you don't need to know this part right now, but the reason being is because alcohol specifically damages the one of the cytochromes in mitochondria, and so then when the mitochondria die, then that's when the AST, that's where that comes from. But you just need to know that that's more than twice. So that's one hint there. Another hint that they give, well, something else that they could give you is if they give you a mean corpuscular volume. Which I didn't give you that here, and I apologize. But if they give you that, what would you maybe look for there that would be an indicator of alcohol abuse?
Is it going to be megaloblastic?
Yes, exactly. Why is it going to be that?
Deficiency in folate?
Yes, it could be. Yes, it could be a folate deficiency. You can have several other deficiencies with alcohol abuse, but yeah, folate's going to be a primary one there. You could also be deficient in B12 depending on how their diet is. Let's see what else here. So a low sodium can also be an indicator of alcohol abuse given a context. Let's see, what else do I have here? Yeah, that's about that. So as far as the question though, the tremors is going to be a big clue in. And then also diaphoresis. So I think I'll have some other questions on this in a little bit that we'll kind of pick this apart as well. But anytime in a psychiatric problem where they make a point to give you physical symptoms, so something other than psychiatric, so dilated pupils, tremor, diaphoresis, anything like that, they're trying to, like, almost like 99 times out of 100, they're trying to cue you in that this is something medically induced. It's not purely psychiatric. If they want you to go with a purely psychiatric diagnosis, they typically won't include any kind of physical exam abnormalities. Let's see, another thing that can clue you in on this is, so with alcohol withdrawal, you can have some slight elevation in blood pressure, definitely not specific, but like not specific to alcohol withdrawal, but that is something that can occur. You can also have some pulse elevation. Then something else that can also be indicative is that he has a history of substance abuse. And so certainly, again, not specific, but it cues you into the fact that this could be some type of withdrawal. And then given kind of the bigger picture here, you can kind of assume that it's that. And then also the time frame. That's another thing that I was going to mention. So there's kind of several different levels of alcohol withdrawal. In the first kind of up to 48 hours, so the first like 24 to like 36-ish type hours, that's when you can have like alcohol withdrawal symptoms that are not delirium tremens. And you can also have some alcoholic hallucinosis in that time frame, but within the 48 to 72 hour range, that's typically when delirium tremens, when DTs are going to set in. So this patient, he had a cholecystectomy a day ago, which means that he was probably NPO for 24 hours prior to that. So this is about 48 hours. So this is when you'd be expecting that. And this is like a classic question for step one. So if they give you a patient in a hospital who had surgery or who's been hospitalized for a day or two, and they have tremors, almost like 9 times out of 10, it's going to be alcohol withdrawal. Yeah, if they wanted you to go like a benzodiazepine route or something like that, they'd probably give you some other indication, like, maybe they have panic disorder, they've been seeing a psychiatrist or something like that. Yes, so then the treatment for this is going to be, you give lorazepam. Oh, those didn't go away, did they? That's unfortunate.
I'm a little slow on the drug uptake. Can you explain why we would pick lorazepam?
Yes, ma'am. So, so the reason for lorazepam is because, so I can't give you an exact, well, I can't give you an exact. So y'all haven't talked about any drugs yet, right?
We haven't gotten to like the psych drugs really.
No, okay. So, so the reason for lorazepam is, so lorazepam is going to, benzos are going to act on the, I'm trying to get this figured out. Benzos are going to act on the GABA receptor here, and so alcohol also acts on GABA, and so the reason that you give lorazepam, or benzo withdrawals and alcohol withdrawals are very similar. And so lorazepam, benzos are going to act on that GABA receptor that has been affected by the alcohol use. Can't get, next time when we have the drugs, we can go into like more detail about that. But at this point, I think it would just be like, I don't want to, like, I think it would just be extraneous information, but it's because they both act on the GABA receptor. Do you want me to go into more detail, or is that okay?
That's good. I think we've technically learned how the GABA receptor works. Maybe
Okay.
someone else stop me. Because we've talked about anti-epileptic drugs, but
Okay. Okay. Yeah. So it's just something to remember because is that you always give a benzo when you have alcohol withdrawals. And specifically, this is more detailed than you'll need to know for this test. Potentially testable for step 1, but lorazepam with an L protects the liver. It's one that's good on your liver. That's how I remember that. So if you have liver damage like this guy has, I want to give him lorazepam because it starts with an L, so it protects the liver. So A, that's a anti-epileptic there. And then fameprazole, what would that be for?
Methanol and it's antifreeze. I think it's like ethylene glycol poisoning.
Yeah. So yeah, you're exactly right. And so what does that act on? What does fameprazole act on?
It blocks or it inhibits alcohol dehydrogenase.
Yep, absolutely. And the reason that you give it is what? So you said when you take, methanol and just methanol, those types of things. Why do we give it? What does it prevent from happening?
It's
Well,
a
with
competitive.
methanol.
Go ahead, Haley. I'm sorry.
It's okay. I was going to say, I guess with methanol, it inhibits the formation of formaldehyde and formic acid, which are toxic. And then ethylene glycol, it prevents the other I think it's like oxalic acid, I think is one of them. But those are toxic, so.
Yeah, y'all are both right, and that's more information than you'll need to know for the test. Yeah, basically, exactly. You just need to know it's a competitive inhibitor, and the reason that you want it is because the methanol and the antifreeze, those actual things that were ingested are not what's going to kill you. It's the metabolites of them, exactly. So we want to prevent those metabolites from forming. Exactly right. Methadone, what would we give that for?
Isn't that for heroin addicts?
Yes, it's a long-acting opioid. So yep, that would be one of the maintenance type treatments there. Phenobarbital, that's not really something that we would want to give this patient. Penicillin, that'd be if they have an infection. Phenytoin, that's another anti-epileptic. And then that would not be a good choice because we don't want him to have a seizure. Okay, all righty. All right, let's go to the next question here. It's clear. All right, here we go. And I will launch next one. Okay, give you a few more seconds there. Okay. Alrighty. Okay, let's share. Looks like y'all got this one fairly decently. So what we're looking at here, he does have obsessive compulsive disorder. So this question would be probably a little more difficult and more enjoyable if y'all had learned what some of these other things were, because y'all haven't talked about anxiety disorders yet, right?
No, not yet.
No, not yet. Okay. So by process of elimination, you can kind of eliminate. I'm not going to go into detail about any of those right now, because that'll be kind of for next time. So I don't want to confuse the issue or waste time. If y'all have a specific question about them, I'll answer that or whatever. But so let's talk about let's talk about how to differentiate between a personality disorder and like some other kind of psychiatric disorder, because although for this test, there's not going to be too much of that going on because y'all haven't learned that many disorders yet. On your next test, that will be like an actual problem you have to deal with is, does this person have like a mood disorder or do they have a personality disorder? So when you're talking, why is it not going back? When you're talking about personality disorders, so you kind of have to look at what the question will kind of try to suggest something to you. So if they want you to go with a personality disorder, typically they're going to use language like, the patient has a long time history of blah, 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 blah. Or since adolescence, this patient has blah, 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 blah. Or the patient has a recurrent, like recurrent problems with relationships for, many years or as long as he can remember, or, more than 10 years, something like that. So that they're going to try to indicate to you the chronicity of the problem. A lot of times they will give you collateral information about relationships that they have with other people and how they react to those relationships. All those are going to be clues for a personality disorder. And typically when you have a personality disorder, you're still going to be like mostly functional. You're going to be like, your functioning will be impaired, but you're still able to get by, if that makes sense. Versus when you have a disorder, usually the problem will try to express to you that this person is very, very limited functionality, if functional at all. So that's one thing that you can kind of look at. Another thing here, so what by definition, how do you diagnose obsessive compulsive personality disorder? What do you need? I mean, not obsessive compulsive personality disorder, obsessive compulsive disorder. What do you need for obsessive compulsive disorder diagnosis?
It has to be disruptive to their normal behaviors.
So that's true, yes. So you have to, that's kind of the golden rule of psychiatric disorders. What else, like specifically to obsessive compulsive disorder, do you need to diagnose this?
You need to have like an obsession with something, like an obsessive thought, and it has to, like, you have to be aware of it, and it has to like distress you that you think about it all the time.
Okay, so you can have obsessions and you can have what else?
Well, and then you can have the compulsions that
Yeah.
reduce the anxiety of the obsessive thought.
Exactly. So for diagnosis of obsessive compulsive disorder, you can have obsessions, you can have compulsions, or you can have both. And you're exactly right. So the obsessions are going to be thoughts, urges, images that are unwanted. They'll generally be described as intrusive. You're right. A lot of times the patient will have fairly good insight. By the way, what is insight? That's a testable term. What is insight?
Kind of like awareness.
Yeah, it's awareness. It's awareness of your disorder and the extent to which your thoughts and your perceptions are impacted by it. So aware that these thoughts are not true thoughts, or awareness that the hallucinations are not really there. Those are gonna, that's all insight. Yeah, exactly. So typically patients with OCD have pretty good insight, which is kind of a good thing and a bad thing. It's a good thing because you can try to use psychotherapy to address it, but it's kind of a bad thing in that, like, they're able to say, I know this idea is crazy and stupid, but it still stresses me out. So that is, so those are obsessions, yes. And then compulsions are exactly how you explained it. It's anything that you do to try to relieve that anxiety that comes typically because of those obsessive thoughts. So yes, so what would be his obsession here? He has several of them. What would they be?
The appliances and worrying about a fire.
Exactly. And then his behavior would be the compulsions. Exactly. Yep. Okay. Are there any specific questions on that that y'all have on this one? We'll talk about the personality disorders here in another question.
I remember seeing something about
Okay.
obsessive compulsive personality disorder and how like it's like dystonic versus like your goals are oriented with, I can't remember how to explain it, but it was
Yes,
like
you're right.
difference between OCD and OCD personality, and I don't know if that's something we need to know. I just remember seeing that and I can't remember it.
Yeah, no, you're exactly right. That's a good point. We can definitely talk about it on this one. This is a good place to talk about it. So yes, so you were going after, I think, ego syntonic and ego dystonic. And so ego
Exactly.
Yes. Okay. Perfect. So ego, and you were hitting the nail on the head. So dystonic is when these thoughts that you have, they're not compatible with who you are and what you think as a person, which is why they cause you distress. Obsessive. So those are going to be characteristic of obsessive compulsive disorder. That's why you have the anxiety that goes with it. Obsessive compulsive personality disorder is where you have the ego syntonic thoughts, which means they are compatible with who you are. For the most part, they're in line with what you value and with what you think. They don't cause you distress because you agree with them, basically. And so that's for obsessive compulsive personality disorder. So how a question would look if they kind of wanted you to go the personality disorder route, it would be, so like, let's say you would have maybe like, I don't know, a 19, 20-year-old who's coming in from college because let's say he was referred by his professor. That's another thing. A lot of times people with personality disorders, they will not come in on their own accord. Somebody else will bring them in. Why do you think that is? It kind of goes along with what I was just saying, but why would a personality disorder person have to be referred?
Because they think that it's how they are, so they don't see anything wrong with what they're doing.
Absolutely. They don't see a problem. They think they're fine. Exactly. With obsessive compulsive disorder, it's bothering them. So that's why they come in. But yeah, exactly. They don't see a problem. It's typically spouse or parents or whomever, friend who brings them in. So yeah, so a patient who is referred from a professor because let's say he kept asking for an extension on his deadlines because he has to turn it in just right. He doesn't want to put his name on just anything. And so when you're talking to the patient, he might say something like, well, I've always been this way. I'll wake up every morning and I'll spend 2 hours planning out my day. And, I was, top of my class because I am the most meticulous and I am blah, 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 blah. And so the difference, because maybe that's hitting close to home with some people, but the difference between that, between being, just being a detail-oriented person and having a personality disorder is that functionality aspect. So if you are saying these exact same things, but you haven't been referred to by your professor because you aren't missing deadlines, then that's normal behavior. But if that behavior that you don't see a problem with is causing a functionality problem, then that's when it's a personality disorder. Does that make sense? I probably went into more detail than y'all were asking for on that.
No, that's great. Thank you.
Yeah, you're welcome. Any other questions on this one? Okay, then we'll go on to the next one. All right. Yeah, and just one more thing that I'll say is that that's kind of the golden rule of psychiatry is that if there's no functional impairment, it's normal behavior. It's only a problem if either A, the person sees it as a problem and it's causing them distress, or B, if functionality is impaired. Okay, I'll shut up now. Here we go. Next problem. Okay, here we go. Okay, give y'all a few more seconds on this one. Okay. Alrighty. So looks like y'all got this one pretty well. So this little baby is normal all the way. So y'all had Dr. Pomeroy's lecture. Someone correct me if I'm wrong, but I believe y'all had. And so you are almost certain to get at least 1 or 2 questions on your exam asking about developmental milestones. It'll probably give you a constellation of things, and you'll either say overall, is this child normal or delayed, or it might ask you specifically which aspects are normal or delayed. So you have to be able to recognize those. And so let's talk about that first. So as far as gross motor, so let's start at 2 months. So at 2 months, what should you expect your baby to do?
Isn't it a social smile?
Okay, yep. So that would be more of like a cognitive, but yeah. So a social smile. They should also probably be able to recognize their parents. So as far as gross motor, so like what kind of movement should they be able to do?
Head
They can
control.
pick up their head.
Yep, head control.
Yeah,
Yep.
their head.
So exactly, they should be able to lift their head and chest when they're lying on their belly. Yep. And then they should also they should be cooing, like making noise like that. Okay, great. So how about at 4 months? Let's go 4 months. You can just give me all of them. What should a baby be doing at 4 months?
They can hold their head up, like they're not just lifting it, but like they can hold it up.
Okay, yeah, so they can. They'll definitely get better with each one as they go along. So yes, didn't mean to throw that. What specifically, what's something specific but new that they learned to do at 4 months?
They're rolling from their back to their front to their back.
Yes, exactly. They roll front to back. Yes. And then sorry, I was reading the chat. Okay, so yes, what should they be able to do socially?
Do they start to laugh, or is that 6 months?
Yep, they'll start to laugh. And then I don't know if Dr. Pomeroy tests on this or if this is just something that they test on step 1, but they'll also, they orient to voice. So if you talk to them at 4 months, they should turn to look at you. Okay, 6 months, what should they be doing?
Sitting for short periods.
Yep, so they should be able to sit unsupported for a few moments. Yes.
Can
What
they
else?
crawl at 6 months?
So I'm glad you brought that up. So crawling is kind of the one milestone that's not really like a standardized milestone. Anywhere from 6 to 12 months, a baby could begin crawling, or they may never crawl. It just kind of depends on the individual person. So that's not really something that they'll ever use as a marker. So I'm glad you brought that up because, so yes, they could be crawling at 6 months or they could never crawl. What is something as far as fine motor that they're going to be doing at 6 months?
Are they doing the raking grasp at 6 months?
Absolutely, the raking grasp. So yeah, so this kind of movement, I don't know, I can't see myself, so I don't know if I'm in the camera or not, but you probably have the idea. They'll also transfer objects from one hand to another at 6 months because they have that raking grasp now. And the reason, this is just a side note, but the reason they have that raking grasp at 6 months is because they lose did y'all talk about reflexes? I can't remember if that's something y'all talk about or not.
Yes, we have.
Yes, you have. Okay, so what reflex do they lose about 6 months?
Lipinski.
Palmer.
So Babinski is which
Morrow.
one? So okay,
Isn't it like a drop reflex? Like if you drop them, like not like we're talking like an inch, but they like move their back differently. You know what I'm saying?
yes, I know what you're saying. So the one you're talking about is the Morrow reflex, and so that one can disappear anywhere from 6 months to like a year, somewhere in that time frame. So sorry, I have a hair on my, yeah. So you're not wrong on that one. Babinski, now which one is Babinski? Someone tell me which one Babinski is.
Sole of the foot.
Yeah, the one with the foot. So when you like go up the side of the foot, the big toe goes backward and the other toes fan. So that's normal actually up until it can be normal up until 2 years of age actually. It can be normal for a pretty long time. And of course in adults, it's an abnormal finding that's indicative of what kind of injury.
Upper motor neuron lesion.
Upper motor neuron lesion. Yeah, exactly. So Babinski, probably they would still have it 6 months. But what, so the reflex I'm talking about, it's the one where you put your finger in their hand and they grasp it, that grasping reflex. So that's the one that I'm referring, that's the one I'm referring to that they have to lose before they can purposefully grasp an object. That's more of a clinical issue, not something probably that they would test you on, but I'm sorry, I don't mean to diverge. Yes, what else, what socially are they gonna do at 6 months?
They can kind of babble, but not really say real words.
Yeah, so they'll be babbling, and they will also orient to what?
They'll orient to voice.
Well, yeah, so they could be orienting to voice somewhere between 4 and 6 months, and they should start orienting to name sometime between 6 and 9 months. And then, and somewhere in the 6 to 9 month time period, what also is going to develop? I'm sorry, that's like reading my mind. What kind of anxiety is going to start developing?
Stranger.
Stranger, yes, stranger and separation will both start developing. And that should last till about 2 years of age. If it starts lasting longer than that, it can be signs of pathology, but I believe you'll get that lecture next week, next week. Okay, at 9, what should they be doing?
Pull to stand, usually.
Yep, they should pull to stand. They may start cruising. That may be more of a 12-month thing, depends on the baby. What else should they be doing fine motor wise?
Pincer grasp.
Absolutely, the pincer grasp, yep. Although that can be as late as 12 months. It just kind of depends on the baby, but typically 9. And then verbally, what should they be doing?
Don't they say data first? Because
Yep.
dads are awesome.
Yep. Yeah, monosyllabic or like repeated, like one syllable repeated, those types of words. And then they should be able to wave bye-bye at 9 months. Then at a year, what should they be doing?
Standing, maybe walking.
Yeah, they should be cruising for sure. They should be standing, and they may take their first steps sometime between 12 and 18 is when you want them taking those first steps. And then they should be able, what should their repertoire be? For words.
Isn't it like 2 words and like 50 total words? 2 word sentences, 50 total words.
That's at what age actually?
Is it 2 years old?
Yeah, 2 years. The reason I remember 2 years is 2 words. Yeah, but so they should have a few words other than mama, dada at a year. Yes, okay. So at 18 months, what should we be doing?
Climbing stairs with 2 feet. I read that somewhere on Firecracker or something.
Yeah, and see the problem with these milestones is that depending on who you get them from, they can change a little bit. So sometime between 18 to 2 years, generally have what we go by in clinicals is two-footed stairs at 2 years, but it can vary with different ones. The big thing though is by 18 they should be walking. They should be able to take steps on their own by 18 months. Let's see. At 2 years, what should they be able to draw?
A straight line.
How about at 3 years? What should they be able to draw?
A circle,
And then at 4?
a cross,
Yep. Yeah. And then at 4.5?
a square,
Yep. And at 5?
a triangle.
Yep, that's right.
Michael, you sound so upset about all of these shapes.
No, I just don't want to interrupt him right when I'm about to speak, like somebody else says it. Or did you mean Michael, the other Michael?
I think the other Michael was the one that was talking all the shapes. Sorry to interrupt. I was just over here
No, you're
giggling
good.
at the monotone of it.
If I'm going too slow or something, let me know and I will pick up the pace. So then also, so by 5, what kind of motor should they be having by 5?
Pretty good motor.
Shouldn't they be able to run at 5? Like that's about the year they start to develop like gross motor functions and like be able to play outside type of deal.
So they should actually be running a little bit earlier. So 2 to 3 is when we say they should be like 2 is kind of when we say they should probably be running by. So 5 is the important thing about 5 is you should be skipping by 5. And 3 generally is when we say you do stairs with alternate feet. Somebody correct me if this is in contrast to what Dr. I just forgot his name, but Dr. Pomeroy, that's it. Somebody correct me if that's in contrast to what he was saying, but generally we say that they should be doing steps with 2 feet by 2, alternating steps by 3, and then they should also be and they should be skipping by 5. So nobody's arguing with me, so I'm going to go with it. Okay. Any questions on this one? Okay, gotcha. Okay, we'll go to the next one. Y'all haven't had the eating disorders lecture, have y'all?
No, it's tomorrow.
I'm sorry. Okay, give y'all a few more
A
seconds.
good preview.
Okay, I'm gonna end it. Okay. All right, so this one, yeah, y'all haven't had that yet. So, alrighty. So with this one here, what do y'all think is going on with her?
It's anorexia nervosa.
Yeah, that's what's going on there. So, so with her, what we're gonna want to do. So this is a really tricky question. Definitely testable on step 1. They'll probably be a little bit nicer to you on your in-house exam here. But so let's talk about this. So a lot of y'all went with the thyroid problem. So some reasons that this is not a thyroid issue. So if we're looking here at her labs, that's someplace that we can start to look. What do these labs look like as far as her TSH, T4, T3? Are those normal or abnormal?
I don't know.
Okay, yeah,
I
I'm sorry.
personally have a question just
Yes.
in regards to lab videos. I mean, not lab videos, lab values. How
Yes.
do you keep them straight? Is there like a trick? Is there any, I mean, I know we got the whatever, the toast alcohol, that's great, but like anything for these other ones, because they mean nothing to me.
I actually don't know the acronym that you were talking about, but so I'm probably missing out there. For me, honestly, I usually end up having to look at a lab sheet when I look at the like if I see them over and over, like obviously there's some of them that I pretty much know, like I may not know the exact cutoff, but I know by looking at it if it's grossly normal or if it's kind of approaching the outside range just because I see it so often. But to tell you the truth, I typically pull up my lab values just to double check myself every time. So I don't have a
Okay, that's fair. I just wanted to make sure I wasn't missing out on some crazy way to actually know these, but good to know.
Nope,
Okay.
you're not. So no, you're not at all. So these are actually all normal. The thyroid is actually a little high, but still TSH is a little high, but still normal. These are a little low, but still normal. We call that euthyroid 6 syndrome, which is a indication of a starvation state, because your body will just kind of naturally decrease its production of things. It'll kind of shut down a little bit. So another way that we can differentiate between so first off, would we be looking at hyper or hypothyroidism with this patient?
It would be hypo if she couldn't lose weight, right?
Hypo if she couldn't lose weight. However, what other symptoms is she all her heat, her cold intolerance, her very, very low BMI, what is all that going to be characteristic of, hypo or hyper?
Hyper.
That sounds more like hyper.
Exactly. So because you have those mixed symptoms, that's not making sense. Also, constipation is a sign of hypo, which doesn't fit with everything else that we're seeing. So that's kind of one sign that she's maybe either has a delusion going on, or she's outright lying about her she's hiding the fact that she is like restrictive or purging or something like that. Let's see. So this is a distractor. Okay. So she has anorexia nervosa. So something to talk about here. What is the main differentiating factor between anorexia and bulimia? What is the criteria?
Purging behaviors are only in bulimia unless it's a
Her
subtype.
the BMI is below 18.5, so
Yeah.
that differentiates it.
Yeah. So Harrison is correct. Stephanie, that's a really, really common thought there, because typically we associate like the purging with bulimia.
Right, but there's a subtype of anorexia. Yeah.
Yes,
Okay.
exactly. Yeah, there's a purging subtype and there's a binge purge subtype and there's a restrictive subtype of anorexia. So you're exactly right. 18.5 is going to be that magic number, or 10% of normal BMI. 10% or less is another way that they might pose the question. So if it's below that, it's automatically anorexia. If it's above that, if there's abnormal behaviors present, then it's bulimia. And something else to be aware of with bulimia, vomiting or purging is not the only thing that can qualify for a bulimia diagnosis. If a patient can be normal weight or overweight as long as they're above 18.5, and they can be vomiting, they can be exercising excessively, they can even be restrictively eating, or like eating restrictively. They can be trying to like sweat it out, they can be using laxatives, any kind of behavior that's an attempt to lose weight can be considered bulimic. Let's see, what else is important here? What are some other symptoms of anorexia?
Missed menstrual cycles.
Yep, amenorrhea is a common one. We call that functional hypopituitarism. So yes, so with that one, some lab values that you would expect to see there is you would have a low FSH, a low LH, and a low gonadotropin releasing hormone, and a low yes, low gonadotropin. Yes, those three would all be low. Let's see what else. Okay, so what are some other symptoms?
Seizures.
So seizures
If it
and
gets bad enough.
huh?
If it gets bad enough, I guess.
Yeah, yeah. So and those seizures are going to be secondary to what? Electrolyte abnormalities. Yeah. So over here you can see sodium is low, potassium is low, chloride is low. Why is chloride low? Could be two reasons.
Maybe she's throwing up.
Yep, if she's throwing up, she's going to be losing hydrochloric acid, HCl. Also, just based on pure restrictive eating, she may not be getting enough electrolytes in. Potassium can be low, secondary to vomiting or secondary to nutrition. She could also, I don't think I gave you a pH here, but her pH, particularly if she was vomiting, would you expect her to have a high or low pH?
High.
High. You would also expect her to have a high bicarb. Magnesium will be low. Phosphate will also be low. Yep. Glucose will mostly be normal because unless it gets really, really severe. Okay. Yep. I think that's. What are some other physical symptoms that you can have? Looking here. What's going on here?
Low blood pressure.
Yeah, so hypotension, particularly orthostatic hypotension, bradycardia, hypothermia. You can also have lanugo, which is really fine hair that develops all over the body. So basically, the reason that we want to so the treatment generally for anorexia is really going to be CBT, cognitive behavioral therapy. But if they have severe bradycardia like this, that's pretty bad. This is pretty bad hypotension. So basically, if it's below like 90 over 60 or so, and if that's below like 40 or so, then you're going to want to admit them for nutritional rehabilitation. Sometimes you can use olanzapine in very refractory cases, but the priority is going to be admitting the patient. Okay, yep. And then if we were talking about bulimia, what addition, or if she's purging with anorexia, or if she's purging with bulimia, what additional symptoms would we expect to see? Or yeah, physical findings.
Scratches on knuckles. Mallory Weiss with the vomiting of blood, I guess, could be a presenting symptom.
Could be.
Chipmunk facies is another one I've heard.
Yep, and what would we be talking about there if they have chipmunk facies?
Puffy cheeks.
Yes, so what anatomically is going on there?
That I don't know.
Okay, that's okay.
Something about the parotid glands.
Yes, parotid gland hypertrophy, which will, yes, give you the chipmunk cheeks. You said the scratches are calluses on the knuckles. Does anybody know what we call that sign? Call it Russell sign. You can also have, yes, so you can have pharyngeal erythema. Maybe if it gets really bad, you could maybe have some tears or something. And then also dental caries from the acid. That's another thing you look for. And with bulimia, primary treatment is also going to be CBT. Indications for hospitalization there would be poor electrolyte counts. What does anybody know what SSRI we might try to use with bulimia?
Fluoxetine.
PowerPoint. Not paroxetine. Did you say paroxetine?
I said fluoxetine.
Yes. Okay, then you're correct if you said, yeah, fluoxetine is the one that we would use there. Absolutely. Okay, and the last eating disorder, we'll just go ahead and talk about it now. I promise the last questions will go quicker because it's the same information. I won't reiterate this information so much. So binge eating disorder, what would we look for there? What would be the defining characteristics there?
High BMI.
Maybe, not necessarily though.
Don't a lot of patients hide it?
It's like a bunch of eating without like reciprocal behavior.
Yeah, there we go. You're right that a lot of patients can hide it, but yes, the defining diagnostic criteria is that they have episodes of a binge eating, right? They feel that a lot of times they'll say they feel they lose control, and then they will not have any kind of compensatory behavior. They're not going to try to purge. They're not going to try to go exercise. They're just going to kind of sit there and feel remorse about it. Yep. Okay, good. All right, we'll move on. And yes, whoever in the chat, Jessica, yeah, we'll have access to the PowerPoint. Okay. All right, here we go. Next one. Okay, I'll give you a few more seconds here. Okay. Alrighty, so we have something to talk about on this one. Okay, so what we have going on here is actually conversion disorder. So it can be really difficult. It can be really difficult to differentiate the different like somatic symptoms is what we call that. And I think Dr. Trotter give y'all that lecture this year. Last year we had a guy from Egypt give it. But I think it was someone different this year for y'all.
It was Dr. Trotter today.
Okay. Yeah, I like Dr. Trotter. He and Dr. Kyles are like my favorite psych people ever. That's beside the point. Okay. So so for conversion, so a lot of y'all went with somatic symptom disorder. So the thing about somatic symptom disorder, what's kind of the defining what's the kind of defining thing that differentiates somatic symptom disorder from conversion disorder? Or first, what's the diagnostic criteria for a somatic symptom disorder?
Isn't it basically like a patient that has a lot of symptoms, but it doesn't show up on physical exam, but she's not doing it intentionally, or he or she's not like making it up or doing it intentionally?
Correct. So a somatic symptom disorder, it can be a very subtle difference from conversion. So you're going to have, it can be one symptom or it can be multiple symptoms with somatic symptom disorder, but it's characterized by very, very excessive worry about it. And but the symptoms are going to be minor. So maybe it's some abdominal discomfort. Maybe it's a slight headache. Maybe it's my throat's kind of sore. And then all the labs, of course, like you said, are negative. The difference between that and conversion disorder is that with conversion disorder, it's going to be a bigger symptom. So with this, right leg weakness is a pretty big symptom. With conversion disorder also, typically they're going to be neurologic symptoms. So common ones are like some kind of paralysis or weakness somewhere in the body, blindness, deafness, aphonia, so inability to speak. Let's see, seizures can even happen, paresthesias. So they're going to kind of be like neurological in origin. Let's see, and the way that you differentiate between a true neurological problem and something like multiple sclerosis, which can be exacerbated by stress, is the neurologic exam will be normal. The symptoms are not going to be compatible with any kind of known illness. So another way that they could present the problem, they could say that a patient has right arm and left leg weakness. That's not typically something that you're going to find with any kind of stroke syndrome, right? That would like require two different strokes to be happening on different side of the brains at the same, different side of the brain at the same time, which is highly unlikely. So that could be something. Or if like, let's say they have like stocking and glove, acute onset of stocking and glove paresthesias. That's not typical because you would have to sever all your nerves at once to have some like kind of numbness going on your entire like front aspect of your hand, right? Normally it should be like just these two fingers or just this side. And especially like obviously diabetes or like some kind of like small vessel disease could cause that, but you wouldn't have an acute onset there. And then another thing, so this patient is very worried that something is wrong. However, that doesn't always have to be the case with somatic symptom disorder. It has to be the case with somatic symptom disorder. It doesn't always have to be the case with conversion disorder. In about half the patients who come in with conversion disorder, they may be like totally apathetic about it. They may be like, yeah, I can't lift my leg, but it's like whatever, you know what I mean? They may be like that, and if that's the case, we call it labile indifference. But yeah, so if the patient has no concern about it, you can pretty much automatically rule out somatic symptom. If they are very worried about it, then you kind of need to look at, is this a major symptom or minor symptom? Is it more of a neurologic symptom or more of like a vague symptom? With somatic symptom disorder, it'll be more vague, like I just generally have some stomach pain. And then another thing that you can use is, so right here, where she's able to stand without assistance from a sitting position, her gait is abnormal, so it's situational. So she only has weakness in a certain situation. With a somatic symptom disorder, they're gonna have the symptom in multiple situations, if that makes sense. They won't just have the stomach ache, like just when they're eating or something. It'll just occur randomly throughout the day, if that makes sense. Let's see. Did I sufficiently explain the difference between those two?
I have a quick question.
Yeah, what's up?
Are both conversion and somatic symptom associated with a stressor?
They can be, but they don't have to be. So that's not a great answer, but either one can be precipitated by something, and either one can also just happen kind of out of the blue. If I had to pick one that's more likely to, I would say probably conversion disorder, but it doesn't have to be. So with, did I answer your question?
Yeah, it does. Thanks.
Okay. With factitious disorder, what will we be looking for here?
Isn't this one also called Munchausen?
It is, yes. So, and so there with factitious disorder, they're going to be faking it, intentionally faking it. With conversion disorder, somatic symptom disorder, they're not faking it, they're really there, but with factitious disorder, it's going to be faked. And what's the difference between factitious disorder and malingering?
Malingering, they're trying to get a personal gain out of it.
Yeah, there's an obvious secondary gain. So I need a note for work. I need, to file this lawsuit. I need my painkiller, something like that. What is it called if we have, say a parent is faking an illness in their child? What do we call that?
By proxy.
Yeah, Munchausen by proxy or factitious disorder imposed on another. Yes, we can move it faster. Yes. Okay, so here we go. Next question. Okay, we'll go a few more seconds here. Okay. So with this one is tricky. We'll talk about this one briefly. So this one, you're going to go ahead with it. So the reason being, in order to be able to give consent, you have to be older than 18 years of age, unless you are giving consent for treatment of a sexual an STD, if you're giving consent for treatment for mental health or some kind of substance abuse issue, or if you are giving consent for contraception or for the care of your child. That could be a pregnant mother giving consent for care, or a mother whose child is already born. So they do have the ability, the mother does have ability to give consent. However, the caveat here is that in emergency situations, the physician can override if there's not like in an instance like this, if they believe that the decision of the parent is not in the best interest of the child. So in this case, it's fairly safe to assume that the best interest of the child at this point would be to intubate, because it looks like they have some sort of infection, and that could probably be treated. In this instance, if it's an emergency situation, you actually don't need consent. And so that also, the way that they could present this question as well is like if it's an EMT in an ambulance, and you have a patient who has like been severely wounded, they're losing a lot of blood, and you're about to intubate, and they say, wait, no, don't intubate, no tubes, but then they lose consciousness. That does not count as consent because it was not informed. And so you would go ahead and proceed with the intubation. So emergency, and unless there is a written DNR or a written like a living will of some sort, then obviously you would abide by that. But if that is not present, or if you can't find it, or whatever, for whatever reason you don't have access to it or something, you go ahead and you intubate, because you can always theoretically undo that. You can always pull the tube out. You can't always put a tube in after they're dead. Yes, I think that was the important thing.
Amanda?
Yes.
So the mom's 16, would that still be the case if the mother was like older? Like the physicians could override?
Yep, it would still be the thing.
Okay.
Yeah, even if, no matter what age the parent is, if they're making a decision that you don't believe is in the best interest of the child, you do what's in the best interest of the child if it's an emergency. And then you sort it out afterwards, that you will be legally protected if you do that. So another common one that they might do are Jehovah's Witnesses with the no blood products. If in the heat of the moment, it's an emergency situation, baby comes in, parents say, no, don't give them blood products. If it's reasonable that the child would survive if you give them blood products, you override and give them blood products in that emergency situation. If it was not an emergency situation, if it was like, let's say like we're about to do a surgery and we know that the child will probably need some blood then, and the parents say no, then in that case you would do a court order. You would not need to go through hospital ethics in any of these situations if it's obvious that it's in the best interest of the child. Hospital ethics are reserved for situations where there's not a clear-cut best decision. Does that make sense? So,
yeah, thank you.
Yep. Any other questions on this one? Okay. Alrighty, next question.
I actually have one question on the last one,
Yes, what's up?
and you might already covered it, but I'm doing other things.
You're good.
If it was a grown up, like post 18, and his wife came in and was like, okay, don't do this, what does the doctor do?
Same situation. If there is not a written like DNR or living will or something, then you go ahead and you intubate. It doesn't matter if the wife or whatever, whoever it is, it doesn't matter what they say, it doesn't matter what age the patient is. If there's not a DNR or a living will that you have access to, you do life-saving treatment.
Okay, thank you.
Yeah, you're welcome. Yep. That's the legal answer anyhow, which will be the correct answer on your tests. What you actually do in practice will be up to you, I suppose. Any other questions on this one? Okay, awesome. Here we go. Okay, I'll give you a few more seconds. Okay. Alrighty. So y'all did fairly good on this one. So what does this person have?
Borderline personality disorder.
Yep, borderline personality disorder. And so we know that because it talks about how He's had this since he was a teenager, multiple relationship problems. There's a history of it even in adolescence. So yeah, exactly. With personality disorders, there's no medical treatment for them. It's generally cognitive behavioral therapy. Borderline personality is special in that this dialectical behavior therapy was developed specifically for borderline. And it's more of kind of like a instructional base, like this is not right to act this way, this is how you should act type thing. So that's what that is. And so with borderline, just to kind of quickly go over the features of it, it's going to be, they're going to have a lot of turmoil in relationships. They'll be very chaotic. They have fears of abandonment where they fear that the person's going to leave them. They react very extravagantly. They might self-harm. They might try to commit suicide. They might do some kind of crazy gesture like I don't know, leave the house and take like everything inside and like just up and leave the other person. Very dramatic acts like that. They have this chronic feelings of emptiness, self-harm pretty much almost always needs to be present for this diagnosis, like self-harm or suicide attempts. And they have like this unstable sense of self. A lot of times they'll also go with mood instability. So they'll say like they're very irritable. Some days they feel up, some days they feel down, but it's not enough consecutive days to count as a hypomanic or manic episode. Just looking at the other answers, a lot of people chose psychodynamic. Psychodynamic will almost never be the right answer. Like, I don't know if I can think of an instance where psychodynamic will be the right answer. So if you ever see that, you can probably just automatically knock it off. It is different from psychotherapeutic. Psychodynamic is like the Freudian, like, let's talk about some deep underlying thought that you don't actually know you have, which is kind of the general consensus that that's not how the brain works anymore. So most people don't do that. There's a few that do, but okay.
Amanda?
Yes.
Did you say that dialectical behavior therapy, is that for personality disorders in general or for borderline personality disorder specifically?
Just borderline specifically.
Okay, thank you.
Mm-hmm. Yep. All righty, here's the next one. All right, a few more seconds here. Okay, yes, so y'all got it. So some highlights of this one here. Major depression, obviously y'all haven't had that yet, so that's not the answer there, as with PTSD. But so talking about the difference between these last three right here. So bereavement is never going to be a diagnosis, because bereavement is like a situation, like you're in a bereavement period. It's not an actual condition, if that makes sense. It's a situation, not a condition. So really the thing we're looking at here is, so first differentiating between grief and which is normal, and complicated grief, which would be considered pathologic. So when we're talking about grief versus just like depression, grief is more focused on the loss, whereas depression, which I know I said I wasn't gonna talk about, but just like real quickly, depression would just be like you would have more generalized thoughts, like you would have feelings of worthlessness, guilt, guilt not related to their death, hopelessness, not related to their death. You'll have things not related to the death. That's how you differentiate those two. And then the difference between grief and complicated grief has to last greater than a year in adults, greater than 6 months in children. That's how you get the difference between those two right there. Yes. Also, psychotic features can be, it depends on the intensity of the psychotic features. That can also bump someone into complicated grief. Or if they have a very, very like intense suicidal ideation. Generally with grief, you may have passive suicidal ideation, and it's going to pertain to longing to be with the deceased. It's not going to pertain to, you know, senses of self-worthlessness, anything like that. It's going to be because they want to be with the deceased. And then with complicated grief, you can have active suicidal ideation. So you might actually have a plan and intent with complicated grief, versus with just grief, they're less likely to follow through. It's more just the ideation. And also with complicated grief, you may have identity disruption. With normal grief, you should still kind of retain your sense of self-worth and your like sense of identity. With complicated grief, both of those can be disrupted. Any questions on this one?
How do you separate it from PTSD? I figured it was complicated grief because, yeah, we haven't really talked about PTSD, but does PTSD just have to be like personal?
So no, I'll go ahead and start the sharing here and I'll answer your question at the same time. So with PTSD, it's so the event has to be life-threatening to either you or someone very close to you, and it has to be witnessed. So that part would qualify. But then with PTSD, you have to meet symptoms in 3 different criteria areas. So one of those is going to be reliving of the event. So things like flashbacks, nightmares, things like that. The second one is going to be increased like hypervigilance, basically. So you feel anxious all the time. You feel like you always have to watch your back. And then the last one is going to be avoidance, which kind of stems from that hypervigilance. You feel that you have to avoid things that remind you of the trauma. And it's like a very disrupting avoidance. Like maybe you don't even go to a part of town because that's where the trauma happened. Or maybe you don't drive because it was a car wreck that you got in, or something to that effect. Maybe you don't pick up electronics because you were a soldier and it was an IED. Is that the word? I'm sorry, my brain's not. Anyways, but it was some kind of like explosive type situation. That, yeah. Did that answer your question there?
Yes, ma'am.
Okay, alrighty. So, okay, alrighty. with this one, what do we have going on here? This one, y'all talked about sleep disorders, right?
With the nightmare
Not yet.
disorder, you remember it. With the sleep terror disorder, you don't, because
Yep.
it happens
Yep,
during
exactly.
the different stages of sleep.
Yes. Do you know which stage which happens in?
I think nightmares during REM and sleep terrors during N3.
Yep, exactly. So yeah, so the main things that you're kind of looking to differentiate between these two right here are really nightmare or sleep terror. Like you said, and you're exactly right, nightmare is going to be during REM sleep. So the patient will remember the dream, they will be consolable, and they will be able to be awakened from the dream. Those are, and also it'll occur typically in the latter half of the night, because that's when you have greater density of REM sleep. Excuse me, sleep terror is going to be, they won't typically be able to describe what they were dreaming of. They won't remember it in the morning. Typically, they're not going to be arousable. Like they'll be in this state of kind of like sitting up but not fully aware. And they won't generally be able to wake them up or comfort them. And with sleep terror, it's going to typically happen in the first third of the night, because it is not happening during REM sleep. It's happening in deep sleep. So stage 3, 4, typically 4. Yes. Real quickly, REM sleep behavior disorder is going to be like your sleepwalking, things like that, which is normal in childhood. However, can be a sign of neuropathology, the early onset, particularly of Parkinson's disease in older individuals. Yes. Everything else here is something we haven't talked about yet, except for sleep apnea. That would generally be, which nobody went with that, so we won't talk about it. Okay.
What was the one that you said with early Parkinson's? Sorry, I just didn't hear the name.
Yeah, no, you're good. So REM sleep behavior disorder, that's going to be the one associated with early Parkinson's. A lot of times before I'll go ahead and put the question up while I'm talking to save time. But a lot of times, even before they develop any kind of like tremor or anything like that, it can be even a few years before, they'll complain of like, my husband started like acting out dreams in his sleep, or there was one neurologist who said this lady came in or this guy came in and he actually, he was a football player in college. He had a dream that he was playing football and he like put his head through the bedroom door because he was acting out his dream. He thought he was tackling someone. So a lot of times it won't be the person, it'll be their spouse. My husband's doing this, my wife is doing this. That'll be typically the scenario there. I think I over answered that. I apologize.
That's okay. I was just curious.
Yeah. But in children, it's normal. Okay, give you a few more seconds here. Okay. Alrighty, so this one, so what do we think is going on with this patient? It's kind of subtle.
Fetal alcohol syndrome. He was born early. He has hydrocephalus, etc.
I see where you're going. And he may have fetal alcohol syndrome, but a patient who has fetal alcohol syndrome will also be likely to have, well, for one thing, their head circumference should be smaller, not bigger, right? But even if they did have fetal alcohol syndrome, that would put them at increased risk probably for what? Because if their mom's drinking alcohol when they're pregnant, what is she might also be doing once they're born?
Probably still drinking.
Probably still drinking, which I think someone said it could lead to child abuse. So the thing to catch here It says a 2-month-old boy rolled off the bed. Should a 2-month-old be rolling?
Nope.
Nope, he shouldn't. So that's kind of the major tip off with this question. And this is fair game for an exam on in-house and also fair game for step one especially. So if you see something, if the story given is not in corroboration with appropriate developmental status, that's a tip off for child abuse. So what would we look at to see if there was child abuse going on?
You want to see if there's retinal hemorrhages?
Exactly. Perfect. Very good. So yeah, so this patient, he probably has such a large head circumference because of internal bleeding. So the head is swelling. Venous shearing is probably what happened. Yeah, so that's probably what's going on here. So yeah, so you would want to do fundoscopy to look for retinal hemorrhages is going to be the big thing. You might also see papilledema, which would be non-specific, but retinal hemorrhages are specific for child abuse. So if a question ever tells you that there are retinal hemorrhages on exam, that is basically a tip off for child abuse. Shaken baby syndrome. Also, cracked ribs would be another one that would be a tip off for child abuse, particularly like on the back right by the spine, because that's where you're going to be grabbing and shaking. Another one would be fractures of long bones, so like a femur, particularly like a one that would, if it's what's the word, diagonal, I think, fracture. Basically evidence that it was twisted. That would be one that you were looking for. And also sharp lines on burns, sharp burn lines would be another one, because that's evidence that they're dipping the child or pouring something on the child, or like putting a child's hand on a stove, something like that. A lot of y'all went with EEG. Even if they were having seizures, that would be to diagnose would be seizures. And even if they were having seizures, an EEG would only be helpful if they're actively having a seizure. Yep. Any questions on that one?
How many total questions are there?
I'm sorry. There's 30. If y'all need to go, you're not going to offend me. I'm trying to move quicker through these. I don't know if I am or not, but yeah, you're not going to offend me if you need to go. I get that. Okay, give you a few seconds on this one. Okay. So, yep, y'all got it with this one. Yeah, not much explaining to do here. All these other things may be pathologic, nocturnal enuresis may be pathologic, but it's not evidence of sexual behavior. It's normal to explore your own body, other people's bodies in a even if it's a genital area in a non-sexual manner as a child. The only thing that would be concerning is if they're simulating a sexual act. That would be concerning. Give you a few more seconds on this one. Okay. So on this one here, so this one was a difficult one. So there are two first-line treatments for alcohol abuse syndrome. Those are going to be acamprosate and naltrexone. So acamprosate, does anybody know what that one acts on? Which receptor? It's fine. I'll just tell you. It acts on the glutamate receptor. It's a glutamate modulator. So acamprosate is going to act on that one. That's testable. Now naltrexone, that one is going to be a mu opioid receptor antagonist, right? So the difference between the two, when you would use one or the other. Now naltrexone, you can still use in a patient who's still drinking some. But acamprosate is generally going to only be given to a patient who's already abstinent to maintain abstinence. So those are the two first line treatments. A lot of y'all went with disulfiram, which is a treatment. However, it's second line. And the reason being, so the way that disulfiram works is it blocks alcohol dehydrogenase enzyme, aldehyde dehydrogenase. And what that does is it basically like intensifies the hangover effect. So what a lot of patients will do if they decide that they want to start drinking again, they just won't take their medicine. They'll skip the dose and then they'll go drink. So it has to be observed, and that's why it's a second line treatment, because you have to watch them take it basically. And then naloxone right here, that one is going to be used for an opioid overdose. So naloxone and naltrexone, those are easy to get confused.
Can you repeat which receptors real quick?
Yep. So acamprosate is going to be a glutamate modulator, and the naltrexone is going to be a mu, so mu, or the little weird U sign, mu opioid antagonist.
Thank you.
Yes, ma'am. Aldehyde dehydrogenase, that's what I was trying to say with the disulfiram, aldehyde dehydrogenase inhibitor. That's what I was trying to say. All right, give you a few seconds on this one. Okay, we're done on that one. Sorry, I didn't mean it like in a mean way, but just we'll stop on that. Okay, so yeah, y'all mostly got this one right. So just real quickly, I'll just talk about the other answer choices on this one. So the difference between displacement and projection. So displacement is when you have anger at or some feeling, could be love, could be whatever, to an external object, and you displace it to another object. So I'm mad at my boss, but I can't yell at my boss. So instead I'm going to go home and be irritable and yell at, my roommate or whatever. That would be displacement. Projection is when you have internal feelings about something, so your own feelings, and you project them, you make them, you perceive someone else as feeling those feelings. So if I am really upset about having to come into clinic on a Saturday, I may I may think that other people in clinic are also upset about having to come in, or I may perceive it as the patient is upset that he has to come into clinic. That would be projection. So displacement, it's an external object, you put it on another external object. Projection is like a feeling that you have not about an external object, just about a situation or whatever, and you are perceiving someone else as having that feeling. So the other person is not the object of your feeling, whereas in displacement, the other person is the object of it, if that makes sense. Let's see. And then suppression. So suppression and sublimation are two of the mature ego defenses. So suppression would be if you ignore it to focus on reality. So I'm upset that I'm having to come into clinic today, but I'm going to put that aside so that I can focus on treating my patients. And then, yeah, so that would be that one. And then I realize I put projection on there twice, but reaction formation would be when I act the opposite way to try to compensate for what I'm doing. So if I, like with the resident situation, if those, so let's say the resident choose the medical student out, well then later on, if the resident acts like overly nice to the medical student or something to that effect, then that would be reaction formation there. So, yeah. I think the most difficult one would be the displacement versus the projection, which the thing to keep in mind, displacement, they're going to be the object of your feelings. You're mad at them. Whereas projection, they feel your feelings. So they're mad at the situation or they're mad at you. Give you a few more seconds. Okay. So, okay, so this one might have been a tip off that it's a psych thing or whatever. Certainly all of these things can be a cause of erectile dysfunction, especially with relevant to psychiatry, SSRIs. However, so some things to like the tip offs to just real quickly here. So normal early morning erection. So if they are having any sort of erection anytime, be it with masturbation, be it with, nighttime, early morning, whatever, then it's not a mechanics problem. It's not a neurologic problem. It's not any kind of physical issue. That's a tip off that it's psychological. Because if it works in one scenario, it's working everywhere else. Now, if they ever say that they are not having an erection in any circumstance, then that would possibly be more concerning for something physical. Another clue would be if it's acute onset in the absence of any kind of trauma. So he doesn't say that he's had any kind of trauma, but it's a pretty acute onset. He can give you a time frame. The past 6 months, it's been a problem. It's not a well off and on or slowly. I don't really know when it started. If it's acute onset, and particularly if they are having erections in any kind of situation. Typically, they'll either give you nighttime, or they'll give you erections with masturbation. Those will be the two different ways that they get it. If y'all have questions, stop me. I'm going quickly to try to get y'all done and out of here. I'm so sorry this took so long. Like I said, they were right. My time management is shit. Yeah. This is the end of our clerkship. So next week I will have time to make sure that it stays under the 2-hour time limit. I'm really sorry about that, but I appreciate those of y'all who are sticking with me. No offense to the people who aren't, but just anyhow. Give you a few more seconds here. Okay, y'all are really good on this one. So yes, so correct answer is the first one. So the thing you want to do when it's a very early on encounter with a patient, you never want to try to confront their delusions or their hallucinations and tell them that they're not real head on. That can actually strengthen their delusions. So if there will come a point in time as you develop the therapeutic relationship that you may then want to start challenging them in an indirect manner, like trying to help them understand. But initially, you don't want to go straight at it and be like, no, that's just whatever, you're wrong. They won't trust you, number one. And number two, it might even strengthen those delusions. Let's see. Another thing that is this is a side note, so I will make it super quick. But if you ever have a patient who is like, I don't really want to tell you, like, do I have to tell you about these things, or whatever, something that they teach us to do. I'll go ahead and put the next question while I'm telling y'all this. But something that I found that's really helpful is if you tell them, no, you don't have to tell me anything. But a lot of people find that sharing these things helps them work through it. A lot of times then, because they know that they don't have to tell you anything, a lot of times then they'll start telling you the information because they don't feel pressured to do so. So that's something that might be helpful there. This one is a tricky one, or yeah, it was tricky for me when I was studying for STEP. I didn't really get this from lecture. Nothing against Dr. Trotter or whatever. He does a great job, but yeah, this one was but STEP oddly enough likes this drug very much. So okay, give you a few more seconds. So yes, so this one is PCP. So it will be important for your in-house exam, and also especially important for STEP to know both intoxication and withdrawal symptoms. And I'm sure Dr. Trotter said this, but to reiterate, withdrawal symptoms are going to be basically the opposite of whatever the intoxication symptoms are, with a few kind of rare exceptions that have some very defining factors. So with PCP, some things that tip you off to the fact that it is in fact PCP. So number one, the patient will most likely be hallucinating. And number two, they're going to be very aggressive. Those are the behavioral aspects of PCP, very aggressive and actively hallucinating. Some other physical findings that can tip you off, they'll mention ataxia. They may mention muscle, what's the word I'm looking for? Like chorea, they may mention that, or muscle like spasticity, rigidity, any kind of abnormal muscle contraction going on. And then they may also mention nystagmus. It can be horizontal, it can be diagonal, it can be vertical, it can even be, what was it? I think they call it rotational nystagmus. There's a name for it. Or it can be multi-directional, but nystagmus and ataxia and muscle symptoms, so like chorea or something, along with aggressiveness and active hallucinations is going to be specific for PCP. And to treat this, it's symptomatic support with potentially a benzo to calm them down if staff are at risk. Just briefly talking about the other drugs on this list, LSD, the main thing there is going to be the hallucinations, which can cause dysphoria or euphoria, depending on what you are hallucinating about. Ecstasy, that is going to, it's important that you know that that one is going to act on the NMDA receptors, the N-methyl D-aspartate receptors. PCP also acts on that. PCP is an activator, so an agonist, whereas ecstasy is an antagonist on the NMDA receptors. PCP will also hit a bunch of other receptors, but the main one that it acts on is going to be the NMDA. That's what causes like the activating hallucinations. With ecstasy, though, some tip-offs for that one are going to be, it's a club drug, so if they're in a nightclub, that could be a tip-off. Also, it's going to first be euphoria and kind of very activating, stimulating, and then they're going to progress to sedation. So first activating euphoria, then sedation, temperature instability. So increased temperature will also be something that is an indicator for ecstasy. You might have some pupillary findings, you could have that may also be something that they put in there for you. Let's see, alcohol intoxication. I don't think anybody needs me to tell them about that. Marijuana, there's two buzzwords for that, for marijuana intoxication. One is going to be conjunctival injection. That is specific to marijuana. Also the time distortion. So that can be manifested as delayed responses. The patient could say that things feel like they're moving slowly around them. Those are two things that are specific for marijuana intoxication. Of particular note, marijuana does not have a specific, a very well-defined withdrawal symptom. So marijuana withdrawal is probably not a choice that you're ever going to want to pick. And also marijuana is the one drug that can give a positive UDS months after its use. So if they ever, I've had questions where, not on in-house, but on STEP, where they'll give you, they'll say that someone has a positive UDS, but they said they haven't used drugs in the past several weeks. What drug are they probably taking? It's going to be marijuana. Cocaine withdrawal, something specific to that one, to cocaine, is that you get vivid dreams. Vivid dreams are going to be something that's specific to cocaine withdrawal. opioid withdrawal, that's you have the whole autonomic activation, so hyperactive bowel, tearing, runny nose, dilated pupils. That's that one. Okay, alrighty. Next question. Yeah. Another thing that's important to keep in mind as far as mechanisms of action with amphetamines, they increase the release of the neurotransmitters, particularly norepinephrine, epinephrine, those types, while cocaine is going to prevent the reuptake largely. And those are both stimulants. Another thing is that cocaine will it can imitate a manic episode. Cocaine can. You know what? This is a tricky question. Y'all don't worry about this question. I'm just gonna give you the answer on this question. Y'all were actually getting it fairly well though. So we obviously know that he has some kind of opioid intoxication on this one, evidenced by the decreased respirations here, by the hypothermia, by the decreased pulse and blood pressure on this one. Also the decreased bowel sounds and pupillary restriction. I think I might have said that. So we know that he's on some kind of opioid, and this one's really just specific to step one. It's not won't. So synthetic or semi-synthetic opioids will not appear on a drug screen. So oxycodone is what he's taking here. Because what a urine drug screen will detect morphine and metabolites, and so anything that is not metabolized into those metabolites will not be detected, and semi-synthetics and synthetic opioids will not be metabolized in that manner. So something to keep in mind for step one and clinically is that synthetic and semi-synthetic opioids will produce a negative drug screen. Also, another one that's important is synthetic cathinones, which is bath salts, which are a form of amphetamines. Those will also not be detectable by UDS, urine drug screen. Okay, give me a few more seconds. Okay, so this one, yes, so it's a personality disorder. It can be a little difficult to differentiate. So this one is going to be schizotypal. So the difference between schizotypal and schizoid, first, I'll do those two first. Basically, the entire cluster A can be a little bit difficult to differentiate between. So that's paranoid, schizoid, and schizotypal. So schizotypal is going to be primarily odd. They have, it's almost borderline delusional, but they're not quite intense enough and inhibiting their function enough to be a delusion. So the fact that schizotypal people may talk funny. So I have had this since my youth. And they may have like sending negative zings. So odd speech, they may be excessively metaphorical and use metaphors that are not commonly used, that don't really make much sense. They can have odd thoughts, magical thoughts almost, like the thought that people's thoughts can enlarge their mole. They will not have an interest really in close relationships at all, maybe some family members, but other than that, not really. But the defining thing is going to be the odd thoughts, the odd speech, the odd behaviors. That's going to be schizotypal. Schizoid, you still have that, they don't typically want relationships, but it's more going to be, they're isolated. They are, the prominent feature is that they're not emotional, they're not interested in sex, they're not interested in friends, they may not even be interested in their own family. That's going to be schizoid. They don't typically have all the associated odd behaviors though. They may have interests, like they may be, like maybe into like weird video games or something, but it's going to be like, they don't have delusional type beliefs is my point. They don't think they can communicate with the TV through the video game or something. Paranoid is going to be, they want relation, like they don't necessarily want to be alone, but they fear everyone else. So paranoid would be more of, it's not that I am not interested in relationships, it's that I don't want them because I'm afraid they're going to take advantage of me. And it's not a realistic concern. Like it may be, I have, maybe $20,000 in my bank account. I'm afraid that somebody is going to try to date me only to get my $20,000. Probably someone's not going to want to put up with that for $20,000, right? So that's paranoid. They also may be very skeptical of the doctor. So like when you're doing a physical exam, they may, like, let's say they come in with an abdominal complaint, they may ask, why do you need to be listening to my heart? Why do you need to be listening to my lungs? You don't need to do that. It's my abdomen. That's the problem. They're going to be very skeptical of you. Yes. Okay. All righty. We'll go on to the next one. All right, give you a few more seconds. Okay, so this one was a tricky one. The main point of this one, what's the BMI right here that we're looking at? It's fourth percentile, which is less than 10th percentile. So that's the criteria, is less than 18.5 or less than 10th percentile for BMI is the criteria for anorexia. So even though these behaviors are very, they're suggestive of a purge type, talking about the vomiting, that sort of stuff. Her BMI classifies her as anorexia. That's the main difference between anorexia and bulimia is BMI, and that's the point I wanted to make here. This patient particularly would not need hospitalization because, or at least at this time, she wouldn't need hospitalization. Assuming her electrolyte counts are normal because her pulse is not excessively bradycardic. She doesn't have hypotension. Her temperature is not overly dysregulated. So she could probably, and I would want to draw labs, but she could probably be treated on an outpatient basis. Body dysmorphic disorder, have y'all talked about that? If not, I won't talk about it, but if y'all have, I'll mention it briefly.
We talked about
You talked about it. Okay. So the reason it's not body dysmorphic disorder, body dysmorphic disorder is not diagnosed if the delusional belief is that you are overweight. That's the reason there. Body dysmorphic disorder would be my nose is too big. I have too much hair on whatever part of my body. I don't like the shape of my jaw. Like that would be body dysmorphic disorder. So yeah, that's basically, it's the same thing. It's just that if the delusion is about you being overweight, your belly being big, whatever, then it meets the criteria for anorexia or bulimia, not body dysmorphic disorder. That's the differentiating factor there. Okay, give you a few more seconds. Okay, so this one right here, most of y'all got this one. So the first thing we want to do, or the next step we want to do is we want to perform a suicide risk assessment because that's going to determine how we care for the patient next. And there will be, probably on your in-house exam, there'll be a question about management of a patient with depression like this. Because right now we don't know if, so it says that she's been having frequent thoughts of suicide, but we don't know if those are just passive. We don't know if they're active. We don't know if she has any plan. We don't know if she has intent. So we want to specifically address that because if they are actively suicidal, that's grounds for a hospital admission. Assuming that they are not like, hectic and not eating or something, obviously you just want to straight away admit them. All these other things are great to do, laboratory tests to rule out other causes, urine toxicology, all those other things are great. And certainly she might need an SSRI or some sort of counseling or psychotherapy as part of treatment, but you want to determine safety right now, so perform a suicide risk assessment there. Alrighty, we give you a few more seconds here. I'll finish that response I was typing to that one person who sent me a message here in just a second. I haven't forgotten about you. Okay, so this one we have something to talk about. All right, so this one is actually narcolepsy. So y'all did talk about narcolepsy, right? I saw in the chat that somebody had said that y'all didn't talk about the nightmares and stuff, which Dr. Burdine, if I remember correctly, didn't go into a lot of detail about nightmares. However, if you mentioned it, it might have just been briefly. You'll need to know that for step one for sure. This you will need to know for your in-house exam. This narcolepsy and obstructive sleep apnea, expect a question on at least one of those topics, if not both, on the in-house exam. So narcolepsy, things that define that are you're going to fall asleep like it's uncontrollable. You just automatically fall asleep at times where you don't want to be falling asleep. So, and this isn't just, I'm so exhausted that when I sit down and am comfortable for 5 minutes that I doze off. This is, I am like driving, I am sitting somewhere in class and all of a sudden it just comes on that I'm very tired and I can't resist it and I fall asleep. Something else that will be characteristic, it's a fairly short nap, so like an hour or less. Maybe even just like 20, 30 minutes, and you will feel refreshed upon waking up. So that's something that differentiates it from particularly obstructive sleep apnea, where you will not feel refreshed upon awakening. So narcolepsy, frequent uncontrollable sleep attacks, you feel they're short, you feel refreshed when you wake up. Cataplexy is another thing. So that is the weakness in his face and knees after an upsetting phone call. So cataplexy is when you feel a very strong emotion. Could be like laughter, like if you hear a funny joke. It could be fear. It could be sadness. Any kind of intense emotion, and you have weakness. You don't necessarily pass out, but you your knees, legs might give out. You may drop to the ground. If and actually, if a patient reports cataplexy, if a problem says that the patient has cataplexy, they automatically receive the diagnosis of narcolepsy, because that can actually present before the symptoms, the sleep symptoms. So it doesn't have to be present for narcolepsy, but if it is, they automatically get it. And then the final thing here that is very characteristic of narcolepsy, wow, can't talk, it's been a long day. Narcolepsy is that the hypnagogic and hypnopompic hallucinations. Hypnagogic means as you're falling asleep, hypnopompic means as you're waking up. So it could be seeing things, it could be hearing things. You hear someone calling your name, you hear some loud noise. But hypnopompic and hypnagogic hallucinations are also characteristic of narcolepsy. So those three things there. And then they can also ask you about what would you find on a polysomnograph, and they can ask you that in-house as well. Dr. Burdine likes his polysomnographs. So you have a decreased REM latency. So these patients with narcolepsy will actually reach REM sleep within like 10 to 15 minutes or less, versus a normal time to reach REM sleep is about an hour and a half-ish, 90 minutes to, about 90 minutes. Yes. And then so while we're here, because I don't have a question about obstructive sleep apnea, but you're almost guaranteed to get one from Dr. Burdine. Is that so obstructive sleep apnea, things to keep in mind, they will probably report a history of snoring, probably not them, probably whomever they sleep with will report a history of snoring. They will probably also be overweight. They large neck circumference, large tonsils. If it's a child, particularly large tonsils is something that can cause that. They will feel tired throughout the day. So they may doze off at times they don't want to, but they don't feel refreshed upon awakening. That's another big thing. They don't feel refreshed when they wake up because they're constantly waking up throughout the night, even though they don't recognize it. So they won't report any symptoms of waking up because it doesn't come to their conscious awareness. But it prevents them from being able to reach REM sleep for extended periods of time, which is why their sleep is not refreshing. Sorry, my voice is going. But another thing that might be reported by a spouse is they might have observed apneic events. They might say like the patient stops breathing throughout the night. That will be another almost dead giveaway of obstructive sleep apnea. And then another thing, so looking at the polysomnograph, is that you will see repeated apneas and awakenings throughout the night. Sometimes they can have as many as like 300 throughout the night. And they will also probably have a decreased sleep latency, time to sleep onset, so decreased sleep latency, sleep onset latency. And they'll also probably have a decreased REM latency, although not as decreased as in narcolepsy. And the reason for those two findings are just because they're so sleep deprived. Okay, there's that one. Oh shoot, I didn't realize it was so long. Okay, yes, alrighty, let's end the polling on that one. Okay, so on this one, so what is going, I'll just tell you what's going on with this one. So this one is actually, so it's factitious disorder, which it seems like most of you got, there was some kind of self-induced thing. So the thing to recognize here, so the reason that it's not like anorexia, or that it's not some kind of nutritional thing like with alcohol, like what you would see with alcohol abuse or something. So blood glucose level will never drop, will never, they are hypoglycemic here. It will never be low unless you have like a problem with the liver, or unless you have a problem with insulin. Those are the two reasons that would give you hypoglycemic, or if you're severely malnourished, but that would be like a very extreme situation. Generally, there's enough gluconeogenesis going on to keep that glucose level at a normal range. So the reason it's not exogenous insulin, maybe they went over this in MOS, maybe if not, it'll certainly be reiterated in SD1. C-peptide, remember that's cleaved with endogenous insulin when it's produced in the body. So if you have C-peptide levels, that means it's endogenous. If you're just injecting insulin, then that means that then you would not have C-peptide levels that are detectable. So that's why it's not exogenous insulin. Sulfonylurea, remember, promotes the endogenous production of insulin. So that's why it's this one in this case. Something else that clues you off to it is that her father is diabetic, which means that she has a source of diabetic medication like sulfonylurea to get that. And this would be factitious disorder. If she had said, oh, I need an excuse for school so that I don't have to take my exams tomorrow or something, then that would push it over into the malingering category. Okay. Were there any questions about that one?
Sorry, I missed it. What was the answer to the last question? Sorry.
You're good. Surreptitious sulfonylurea use.
Got it. Thank you.
Mhm. Okay, give a few seconds. Okay, so this one right here, y'all did well on this one. So this one is somatic symptom disorder. So I know that Harrison had asked a question. I think it was Harrison. I think he's gone now, but I'm still going to answer it. He had asked at the beginning, like, how would you differentiate conversion from somatic symptom? So you see that this one right here is more of a vague thing. So it's like abdominal pain. It's not very specific. It's not neurologic. So those are two tip-offs that it's somatic symptom disorder. The fact that she's a lot of times with somatic symptom disorder, they'll have gone to a lot of different physicians. That's another thing. With conversion disorder, typically it's significant enough that the first physician that sees them is going to they're going to do something. They're going to try to diagnose something. They're not going because it's going to be such a significant impairment that they're coming in with, like they're going to report blindness or something. They're not going to just kind of brush them away and be like, okay, it's going to be so significant. And it makes such a point that she is unable to focus on anything else. With the conversion disorder, she did say that she was very anxious about it, very worried that something might be wrong, but it wasn't to the point where it's disrupting her life. With this one, she's unable to focus, so she's not performing at work. She's having to take a leave of absence from work. Typically with conversion disorder, the symptom itself is more debilitating than the anxiety about the symptom. So the fact that I can't see, the fact that I can't move my leg is what's more impairing because I can't see or I can't move around versus my anxiety about it. With somatic symptom disorder, I'm so anxious about it that that's what's impairing me, not the pain itself, not the symptom itself. Okay, and then with illness anxiety disorder, the reason that this one is not illness anxiety is because with illness anxiety, you have no symptoms. You're just like, oh, I'm so concerned that I'm going to get multiple sclerosis, or I'm so concerned that I'm going to get coronavirus. So I have no symptoms. I have no shortness of breath. I have no runny nose. I have no fever, but I'm so worried that I'm going to get coronavirus. That's what differentiates it is the absence or presence of symptoms. With illness anxiety, they may report like, oh, well, one day I had a headache, but it's not going to be, I have a headache every day. Does that make sense? There's not really any significant symptoms to speak of with illness anxiety. And the reason it's not factitious on this one, someone had put factitious. The reason it's not factitious on here is because I guess theoretically it could be if you work through it far enough, but it doesn't seem like she is causing this because she's so anxious about it, and it's to the point where it's preventing her from working. So it's not to her gain. People with factitious, I'll go ahead and put that question while I'm still talking, but people with factitious disorder, they're not going to really present as anxious about their symptoms. They're going to be a very compliant patient. They're going to be very polite. Oh, doctor, whatever you need so on this one, I relaunched. It'll be the question 1 in 26 again. It'll be, oh, doctor, whatever tests you need, please do. That's kind of going to be the difference there. And their symptom is not going to match with factitious disorder. Their symptom will not match up with findings. It won't just be that there's an absence of any findings. It'll be that it's not that one of the findings is not consistent. Like they'll have a really high fever, but no reflex tachycardia with the high fever, something like that. With factitious disorder. Give you a few more seconds on this one. Oh gosh, these, oh wait, no. Haha, LOL, that's the wrong question. Okay, so on this one, yes, y'all are exactly right. Yeah, so you're not going to resect the mass. And so the reason being is that you don't have consent, and the fact that this is not an emergency situation. If it was, you opened it up and you like accidentally nicked the aorta, God forbid, or you open it up and you see something that's an emergency, like they are likely or have the possibility of dying on the table if you do not address it, then you need consent. If it was an emergency, you don't need the consent, you just go ahead and treat it without consent. But if it is, if it's something that can potentially be treated at a later point in time, you need the consent if it was not something that you were authorized to do at the onset of the surgery. Even though it does increase, cost of medical care and potential for an infection and that sort of stuff, that doesn't, that's overridden by, patient autonomy in that instance. We're almost done, I promise. So this one is not one that you'll be tested on your in-house exam. So I'll just go ahead and give you the answer on this one. So with this one, this is age appropriate behavior. This will be tested on step 1. You almost be guaranteed to get at least one question about it, maybe more than one question. And the reason being on there is so up until about 6 years of age, it is normal to have an imaginary friend, which can be like some amorphous creature. It can be a person, it can be an angel, whatever. It's totally normal to have it. And it's actually, they think that the reason is because it helps like a child, it's not, it doesn't inhibit their functioning, and it actually helps them because they can like kind of bounce off ideas off of them, like social situations. They can pretend to act out social encounters with their imaginary friend, which helps them then in an actual social situation. So you're almost guaranteed, the way they'll put the question is they'll have a patient who's 6 years of age or less. I want to emphasize that. If they're like 10 or 15 and they're having an imaginary friend, that's an issue. But 6 years of age or less, they have an imaginary friend, and then they'll give some kind of family history of schizophrenia or some kind of psychotic disorder, and then they'll throw out what's the matter with them, and it's going to be normal behavior. Unless it's inhibiting functioning, but I don't think they would I don't think they do it that way. They want to see that it's normal to have an imaginary friend. 6 years of age or less. Another thing that's important, not tested on your exam, but important for STEP, is that when childhood grief, it is actually considered normal if they have hallucinations, particularly of the deceased. In adults, that is not considered typical grief reaction. That would probably push them over into the category of complicated grief, depending on how intense the hallucinations are. But in childhood, it could be normal for them, if their grandmother died, to have hallucinations of talking to their grandmother, seeing their grandmother in the room, hearing her voice. That's all considered normal grieving process in children. So they might ask you that on an exam as well. And of course, they'll give you some kind of family history of schizophrenia to try to distract you. Two more questions after this. All right, give you a few more seconds. So y'all mostly got this one. So the next thing you want to do is you want to evaluate the patient without his mom in the room. Any patient that is able to answer questions themselves, you typically want to have a period of time just with the patient where you ask them some questions. There's of course some situations where someone is so intellectually or whatever impaired that they can't answer questions by themselves. And so obviously that would be a rare circumstance there where you would not want to evaluate them alone, but any patient who can, you want to evaluate them that alone. That also includes adolescents. That's a very important part of the adolescent exam. So they might ask you a question about that. Yeah, let's see, what was the other question on here? The answer that someone picked? About the, so yeah, so that someone had, so D right here, a couple of y'all picked D. So that might be a valid part of the exam. In fact, we do that a lot in psychiatry when we're talking to children. We'll have the child first tell us what's going on, what's the problem, then we'll say mom or grandma or whoever, do you agree with that assessment? So it is good to ask if they agree with each other. It can also give a clue to maybe some kind of interpersonal problems that are going on at home or wherever. But yeah, you do want to get the patient's own perspective. That's something that is very testable. And one other thing that is really testable, I don't have a question on, it's ethics related, and I'm sorry to talk while I have the question up. I hate it when professors do that, and here I am doing it. But a question that they'll almost certainly give you on your MBME, and I had problems with it. They gave me like several of them on my MBME for psych. Is so like they'll have a patient, particularly like they'll have a man coming in with like a knee infection. It's gonorrhea, so he cheated on his wife. His wife will call the office and say like, "Hey, I demand to know how my husband doing," or she might call and be like, "I'm so concerned about my husband. Like, please tell me what's the matter with him. What's his diagnosis?" If the patient doesn't have authorization, or if the patient hasn't authorized his wife to get information about his health, you can't tell her anything, even though you might want to tell her, "Oh, it's okay, it's just an infection of the knee or something," but not give her like what species it is or whatever, like not tell her it's a gonorrheal infection. You can't even do that. You can't tell her anything. So legally, I mean, how you actually practice is up to you, but
Does that even apply to HIV? Because I remember reading somewhere that you have to report the HIV infection to the spouse, but I guess gonorrhea is different, even though they're both STDs.
so the way it works with HIV, that's a great question. I'm glad you brought it up. So you do have to report it. You actually have to report all STDs. They're reportable. But the way you report them is you report them to the health department, and then the health department will contact the patient to get a list of all his sexual or her sexual contacts and whatnot. And the health department does the contacting. So it's not your responsibility as the physician yourself to tell anybody. And it's not your responsibility to make the patient tell anybody. You report to the health department and they do all of that logistical work for you.
So it's not the doctor's responsibility, but somebody at the health department is going to call that man's wife and be like, "Hey, he has gonorrhea."
I don't know exactly how it would work, but basically,
Wow.
yeah,
sorry.
it's the health department's problem at that point. Yeah. Kind of, yeah. Yeah, you could, yeah. Now how you actually practice again is up to you, but legally and according to your answers on STEP and on in-house exams, that's how you don't disclose it. Did I ever share? Oh, I never relaunched polling for this question. Sorry, that's why nobody's answering. Another way to think about that too, Michael, is that your responsibility is to your patient. And so even if the patient's spouse or sexual partner or whatever is, even if they're your patient as well, in this instance, is that it's as if they're not. So your responsibility is solely to your patient, unless they're an active harm to themselves or others, whatnot, then, suicidal, homicidal, then you obviously have to, get the authorities involved and whatnot. But even in that instance, if they were suicidal or homicidal, I guess suicidal is not a risk to others technically, but even if they were homicidal, you would not go and contact that person yourself. Like if they were like, "I'm going to go and, kill Bobby at work," you're not going to go and hunt down Bobby at work and tell him. You're going to tell the police, and it's up to the police to go tell Bobby at work to, or to go, protect Bobby at work by probably arresting the patient.
Gotcha. Thank you.
Yeah. All right. A few seconds on this. Okay. Yeah, so good job on this one. So this patient, yes, is avoidant. And so the cluster C, the anxious, fearful category can be a difficult, they can be kind of difficult to tease out as well, kind of like those in the cluster A, that category. They, I'm sorry, this isn't anxious, fearful. Anxious, fearful is the first. Yeah, no, this is anxious, fearful. Okay, yeah, so anxious, fearful. So that's the avoidant, dependent, obsessive compulsive, and yes, those three. And so with this one, so avoidant, they're going to avoid others because they have a fear of rejection. So when this patient says that, you know, who would want to be friends with me anyway, she obviously has a negative view of herself. And so she's anticipating rejection. And so therefore she doesn't want social interaction. Same thing you can see with this, she's overreactive to slight criticism. So that's the same, that's another cue that she has self-confidence issues. So avoidant and dependent and all of the cluster A are, I'm sorry, not dependent, avoidant and all of the cluster A are going to not be involved in, they're going to kind of avoid social interaction, but for different reasons. So you have to look at the reason that they're avoiding it to determine which category they fall into. Let's see what other answers people picked. So the reason it's not schizoid is, so she is unhappy, it seems, about her her lack of social interaction. She says her mood is unhappy. And even though she says, I prefer to work alone, that's more of a kind of cop out. She prefers to work alone because she doesn't want rejection, even though she really would like a relationship. So a person with schizoid personality also is not going to care typically, excuse me, what other people think of them. So the fact that she's overreactive to criticism is not typical of someone with schizoid personality disorder, because a schizoid personality disorder would not care at all. They would not give a shit. Paranoid, the reason it's not paranoid is because she's not actively thinking that other people are out to get her. It's more confidence issues, self-esteem issues. Now, if she said, I prefer to work alone, you can't trust other people, I prefer to work alone, I don't want anybody interrupting my work, or I don't want anybody sabotaging me, or something to that effect, indicating some kind of mistrust of others, or that others might have bad intentions, then that would be paranoid. And an antisocial, so this is certainly antisocial. I hate kind of the name antisocial personality disorder because it makes you think that they are avoiding social interaction, but antisocial, what you're going to see is like a disregard for the rights of others, no remorse. They'll typically have a clause in there that says the patient does not express remorse. They laugh about, like, oh yeah, like I, punched Billy. They won't feel remorse about it. They'll have a history of cruelty to animals, maybe. They'll have a history of running in with the law, possibly, stealing, raping, violent behavior, and particularly that lack of remorse is something that's going to be there too. Something also about personality disorders, I'll go ahead and put the next question, this is the last question. But with personality disorders, as y'all know, it has to be 18 or older. So automatically if a patient, if in a problem, if a patient comes in who is 16 or whatever, even if they have personality disorder tendencies, you're not going to diagnose it for the problem. In real life, maybe. I mean, if, a lot of times they're not going to, grow out of it or anything. But they'll grow into the personality disorder, so you might as well diagnose it. But for the purposes of questions, you will not diagnose it if they're less than 18. But the big bad little brother, I guess, of antisocial personality disorder is conduct disorder. And the only difference between those two diagnoses is their age, less than 18 or 18 and older. Something on STEP, well, I'll just mention it briefly. It won't be tested on the exam, but something on STEP to differentiate antisocial personality disorder from is pyromania. A lot of times it can sound similar in the question, but in the question stem, it's only pertaining to fire. They'll be setting fires on different property. They have a fascination with police. Firefighters, not police, that sort of thing. They'll start a fire just to see how long it takes the firefighters to get there. So if it's only regarding fire, it's not antisocial. Okay, a few more seconds. Okay. So this one right here is one that I wasn't very familiar with. It's potentially testable in-house. It'll probably be very straightforward if they test you in-house. It's also very testable on step one. Step one likes this and PCP for they like all the drugs on step one, honestly. But so this is inhalant use. And so the big tip off right here is the rash, the eczematous rash around the nose and mouth. That's because they're, breathing it in from a bag or whatever. That's why it dries out the skin. That's why you get the rash. They may even say that there's a blue color or whatever color. It could be any color, but a lot of times they'll say blue to try to make you think, oh, they're hypoxic, but it's really just blue paint. So if there's any kind of rash or discoloration or something that they talk about being around the nose and the mouth, that's a huge tip off for inhalant use. If it was just hypoxemia, it would be just around the lips. You're not going to have blue around the nose. Another thing, so depending on what they're using for, sorry, I keep getting hairs in my mouth. Depending on what they're using for the as the inhalant, they could have some neurological symptoms. So that's what the tremor is trying to clue you into. Neurologic deficits, so you can have sudden sniffing death, which is just like on the first use, with just like one or two breaths, they drop dead or they have major brain damage. That can happen with inhalant use. And then another way that they might test this is that it's a very abrupt on and a very abrupt off, like less than an hour. So a patient, the problem may present as, on step one, the problem may present as a patient is brought to the emergency room by their friends. Typically it's going to be an adolescent. This is kind of an adolescent drug. It's maybe something that they start with before they go on to something else. So it's going to be typically an adolescent patient. Anyhow, but so you have an adolescent patient, they come in, their friends bring them into the ER. They're either unconscious or they're very very sedated. Anyways, yeah. And so so they're going to come in but within an hour they're fine. Like they may take a nap and then they wake up, and in 45 minutes to an hour they're totally fine, no residual symptoms. Maybe a residual tremor or something like that, but by and large, like their alertness has returned and everything. So a very abrupt on, a very abrupt off. And they won't test you specifically as to like, is it toluene that they used, or is it, spray paint, or is it glue? They're not going to test you like that. They'll just put one inhalant on there, and like they'll only put toluene as an answer choice, or they'll only put, just inhalant in general as an answer choice. You won't have to differentiate between different ones. Okay. Let's see, that was the last. Okay, so sorry it took so long. What questions do y'all have? Or do y'all just want to leave? Let's see, I'll stop sharing that. And you can always email me the questions if you want. Let's see. There we go. Any question? What questions do y'all have? Oh, thank you, Stephanie. So sorry it took so long. It's been, we have our board exam this week and lots of stuff. So I didn't have time to go through to make sure it was under time, but it will be next week. I promise I'll keep it to 2 hours. I'll stay on till everybody leaves in case anybody has a specific question. If you want a copy of the recording, then let me know and I'll send it. Just shoot me an email or text or something. Y'all are so welcome. Let me make sure nobody said anything that I need to email them about.